Okay, anticonvulsant bipolar medications. Here they are. Now, the ones that are in bold treat mania. Okay, Topamax and Neurontin don't work, but they're used for other purposes in bipolar. And Lamictal, which is an anticonvulsant, does not treat mania. It treats depression. So we're still talking about treating acute manic episodes. We're talking about these. Now, let me tell you something. Tegretol is a very problematic drug to use, and for lots of reasons. Side effect-wise, it's a problem. It causes birth defects, but also it actually interferes with its own metabolism, and so it has an effect on liver function. So you have to frequently do dosage adjustments to deal with the fact that it's being metabolized differently over a period of time. Equitro is the sustained release version of this, and it has fewer drug interactions. It's a little bit better side effect wise, but typically this is not going to be a first-line drug because it's just more problematic. So if you look at the anticonvulsants that treat mania, Depakote is really the one that's going to be used the most. If you look at most of these drugs, they cause these problems. The exception is Lamictal. We'll talk about that after our break. Lamictal can cause rashes, but tends to have very few side effects. It's really the only bipolar medicine that has very, very few side effects, except for rash. Okay, and then Depakote. I'll do this one slide, then we'll take a break. If you look at sort of head-to-head comparison studies, it seems to be as effective as lithium for classic euphoric mania. The advantage is that it's somewhat better tolerated than lithium. Okay, they have actually similar side effects in some respects, but it's a little bit better tolerated. It has been used, although the research isn't strongly supportive of this, but it may treat rapid cycling. It clearly is the best medicine, as I mentioned before, for dysphoric mania. Let me just mention something, okay? And that is lithium is used a lot in other countries, and not as much in the United States. And I may have mentioned this in our last class, I don't remember, but only 30% of people with bipolar in the United States ever are tried on lithium, and the experts are saying that's a real mistake because it's a very good bipolar drug. And also, as I mentioned in our last class, it's the one drug that has this huge impact on reducing suicide rates. Remember that 7-fold decrease in suicides. So if you look at patterns of practice in the United States, you're going to get a lot more people put on Depakote than on lithium, but that is a prescribing bias. It's not shared by other parts of the world like Europe, England, Australia, and so forth, where they use a lot of lithium. But the other advantage of Depakote, and then we'll take our break, is for all these anti-manic drugs take about a week and a half to really work. Now, you can knock someone out with antipsychotics. You can knock them out with tranquilizers to get rid of the severe agitation. But really, it takes about a week and a half before it really targets grandiosity and decreased need for sleep and flight of ideas and all that kind of stuff. With Depakote, if you get real aggressive with the dosing, you can turn the corner in about 4 days. Okay, so I think, and that may be for better or for worse. I think that in a managed care environment, the reason it's used a lot is let's get these people out of the hospital as quickly as possible, and we can get them out quicker if we use Depakote. But what's the other side of the coin? We talked about before, if you knock people over with side effects in the long run, they may be less compliant with medication treatment. So it's a two-edged sword. Okay. Now, it may seem like we're spending disproportionately large amount of time talking about bipolar. I think the reason for that, one is it's complicated, but the other thing too is probably in psychiatry, this is where the most damage occurs to human beings is inappropriate diagnosis and inappropriate treatment. Okay, so that's one reason. Okay, so go for 20 minutes and we'll take a lunch break. Depakote levels here. like with lithium, it's not the amount you take that matters as much as the level. So you have to monitor blood levels of lithium. Likewise with Depakote. And with Depakote, when you take Depakote, a whole lot of it binds to proteins in the blood, like albumin, for instance. And when it's bound to a protein, it can't get into the brain. And so unless you have a level that's at least 50, 100% of Depakote is locked onto blood proteins and can't get into the central nervous system. And once you exceed that, then you have what are called free molecules that are floating around in the bloodstream, not bound to proteins, and that's what crosses into the brain. And the reason I'm mentioning this is because I've seen over the years some people, and mostly these are kids, teenagers, and they're not doing very well in their medicine, and I'll ask, well, what was their latest Depakote level? And sometimes I've been told, well, they haven't really taken any Depakote levels recently. It's like, what? Well, it was 40. Oh, I think I have an idea of why it isn't working. Because it's not getting in the brain. Okay, so it has to be within this range here. Now, this, in addition to the potentially problematic and sometimes dangerous side effects, this is also something that's really a big deal, and it's polycystic ovaries. Now, Depakote was used for a number of years prior to being used in psychiatry because it treats epilepsy. And so in women under the age of 20, if they're not monitored carefully, they can develop polycystic ovaries, which, if allowed to go on for very long, can cause permanent infertility. And this, unfortunately, was discovered after it had been used for years and years to treat kids with epilepsy, and then they end up later and they can't have kids. I mean, it's just obviously a horrible outcome. Now, it says women under the age of 20, 80% can develop polycystic ovaries. After the age of 20, the rate drops down to 13%, so it's not zero. So here's what has to happen, and that is if you have pre-adolescent girls that are taking Depakote, then you do a sonogram of the ovaries at the very beginning of treatment, and then repeat this 2 times a year. And I don't know the particulars about what they look for, but radiologists absolutely can detect changes in the ovaries that signal, we're starting to move in that direction, so you have to stop the Depakote and go to a different medication. After puberty, though, weight gain and irregular menses, but I want to add something that may actually be another and more common finding is called hirsutism, which is abnormal growth of hair. So you get 16, 17-year-old or even a 33-year-old woman starts getting excessive facial hair or hair on their chest. So weight gain, irregular menses, or abnormal hair growth is a big red flag that they may have begun to develop polycystic ovaries, and then you get it checked out and have to change the medicine. And my great concern here, again, is all these kids that are being put on Depakote for all kinds of different reasons and not monitored carefully, especially kids that are, inner city kids, and they don't have good health insurance and that kind of stuff. Okay. Now, Topamax, for a while they thought, well, maybe we can add this to the list of drugs to treat mania, but it really doesn't seem to be very effective. But it's frequently given as an add-on drug. Remember I said most people that are successfully treated have taken 4 drugs. It's not unusual that this will be an add-on drug, and mainly because of these first 3 things up here. You have high rates of binge eating disorder in bipolar disorder, high rates of obesity, and a lot of the drugs will cause weight gain. And so this drug is one of the only psychiatric drugs really that causes really substantial weight loss. Most people that are taking Topamax are losing a pound a week without dieting or without increasing their exercise. Now, if you happen to be taking Depakote or lithium or Zyprexa, sometimes people are putting on a half a pound or a pound a week to add Topamax, and so then it makes it weight neutral. It's not losing weight, but they're not gaining weight. So now, I don't know if this is true or not. There have been some jokes about that. Some people have gone into their primary care doctor and faked being bipolar so they could just get Topamax, so they could lose weight. A pound a week without dieting. This sounds appealing for many people. It treats pain. It's FDA approved for migraine prophylaxis. The rate of migraine headaches is 3 times greater in bipolar patients than it is in the general population. So it's always nice if you have a drug that kills several birds with one stone. And also there's some data suggesting that as people are in recovery from alcoholism, that it maintains longer periods of abstinence if people are taking Topamax. Now, the bad thing about Topamax is that even at low doses, it can oftentimes cause cognitive problems and mainly memory problems. And here we're talking about the ability for new learning. It's like I can't remember I parked my car, that kind of thing, okay? And sometimes it's substantial. And again, this is, I'm sure, a joke, but they say that the reason that people are losing a pound a week on Topamax is they forget where the refrigerator is. And because of the cognitive impairment, some people jokingly call it Dopamax. Makes you dopey, so. Anyway. Okay, now Neurontin, that doesn't work at all to treat mania, really does have a place, though, in treating bipolar, because last time around, we talked, there's a lot of comorbidity, and anxiety disorders are seen very frequently in at least half of people that have bipolar. And I think I mentioned this in my last class, anxiety disorders and substance abuse, if they are comorbid with bipolar, if you don't treat those, the outcome in general is a lot more poor. So you've really got to aggressively treat bipolar disorder, but also treat the comorbidities. The problem, though, is that the drugs that work the best for treating anxiety are antidepressants. In fact, as we're going to see, antidepressants may actually be better at treating anxiety disorders than they are at treating depression. But what do antidepressants do? They can aggravate bipolar. So Neurontin can be used for treating a whole array of anxiety disorders, with the exception of OCD. OCD is absolutely clearly due to inadequate serotonin function, and Neurontin does not have an impact on increasing serotonin.